Alright guys, so our case study is on bronchiectasis, and here's a photo here, just to give you guys an idea of what it looks like. Alright, and most causes of bronchiectasis are going to include some combination of bronchial obstruction and infection. In developed countries such as the US, cystic fibrosis is going to be the most common cause, with pulmonary infection being the most common cause otherwise in non-cystic fibrosis bronchiectasis, or NCFB. And in other populations, such as Polynesia, Alaska, Australia, and New Zealand, NCFB can occur in as high as 15 per 1,000 children. And although this is not well defined, it is believed that a possible mechanism for post-infectious NCFB is a significant lung infection during early childhood, which causes anatomic alterations of the developing lung that allows persistent bacterial infections. So as a result, the continuous bacterial infections would lead to bronchiectasis. So some other causes that aren't as common include a mucociliary disorder or immunodeficiency disorder involving low levels of immunoglobulin G, IgM, and IgA. It also can be associated with patients who have rheumatoid arthritis, COPD, and inflammatory bowel disease. So the causes can be classified into a few broad categories, such as acquired bronchial obstruction, congenital anatomic defects, immunodeficiency states, abnormal secretion clearance, and miscellaneous disorders such as alpha antitrypsin deficiency. All right, so moving on to the signs and symptoms now. So for vital signs, we're going to be looking for tachypnea, tachycardia, and hypertension. And for breathing, accessory muscle use and pursed lip breathing. And then for appearance, cyanosis, digital clubbing, peripheral edema, and this could include distended neck veins, pitting edema, and then you're also going to want to look for the hallmark signs, which is chronic cough and large amounts of foul-smelling sputum. Thought about putting a photo of sputum, but I couldn't really find it, and so I spared you guys that. And diagnosis, chest x-ray, you're going to be looking for overinflated lungs, increased opacities, crowding of the bronchi, and atelectasis. And they used to do bronchs to determine if a patient had bronchiectasis, but now they've moved on to high-resolution CT scan. So that's going to be determining if the diameter of the bronchus is wider than the adjacent pulmonary artery, and if there's a failure of the bronchi to taper, and if you're seeing bronchi in the outer 1 to 2 centimeters of the lung fields. And then furthermore, we have the spirometry test to determine whether bronchiectasis is going to be obstructive or restrictive with the lung pathophysiology. As far as treatment goes, we have our oxygen therapy, we have bronchopulmonary hygiene therapy, which includes CPT, high-frequency chest wall oscillation, and of course suction, because the hallmark sign, as mentioned, is going to be large amounts of foul-smelling sputum, so definitely going to want to suction. And then the lung expansion therapy, so that's IS, centric spirometry, and then our aerosolized medication therapy. So that's going to be just the albuterol. What isn't recommended is going to be the corticosteroids, and that's because these agents may cause bronchospasm and they're not approved by the FDA. And then as far as mechanical ventilation goes, this would be in a case of a patient having acute on-chronic vent failure, which occurs with severe bronchiectasis. And if the is indicated for reversal of that, then possibly mechanical ventilation would be indicated.
Our case study scenario is on bronchiectasis. Our patient's name is Miss Casey, a 70-year-old woman who came in to consult her physician regarding an increasing productive cough over the last several days. She has a history of frequent episodes of bronchitis and sputum production, including a childhood history of frequent episodes of cough, bronchitis, and pneumonia. Sputum production had increased over the last several days before she arrived. It was yellow in color with streaks of blood. The patient mentioned producing as much as a cupful of secretions. She denied having any fever or chills. At the age of 26, she was diagnosed with bronchiectasis after undergoing a bronchoscopy procedure. She did well until she reached her 60s when she noticed increased dyspnea with activity and cough and wheezing. In addition, she was hospitalized twice for pneumonia. On physical examination, there were diffuse wheezes and crackles, bilaterally, and new lower extremity edema. Her oxygen saturation was 90 on room air at rest. Chest radiographs showed a volume loss on the left lung and pleural changes over the left apex and base, along with a CT scan of the chest that revealed cystic dilation of the left lower bronchus. On spirometry, her FEV1 was 0.82 liters, 46 of predicted. An echocardiogram revealed elevated pulmonary artery systolic pressure estimated at 70 to 75 millimeters of mercury. Due to her history of bronchiectasis and increasing sputum production, she was given 500 milligrams of oral azithromycin as a single dose on day 1 and 250 milligrams on day 2 to 21, prescribed for a total of 21 days. And she was given 40 milligrams of oral prednisone once a day with a tapering dose. Her sputum culture was positive for Pseudomonas aeruginosa. The antibiotic was changed to 500 milligrams of levofloxacin. In addition, it was noted that with activity, her oxygen saturation dropped to 86. Therefore, home-based oxygen therapy at 2 liters by nasal cannula was prescribed. This now brings us to the respiratory care plan. Subjective findings were productive cough, hemoptysis, worsening in the past several days, increased dyspnea with activity. Objective findings: vital signs appear to be normal with exception of increased blood pressure. Observed moderate amount of mucopurulent blood-streaked sputum. Breath sounds revealed coarse crackles over the left lower lobe. Outpatient sputum culture was positive for Pseudomonas aeruginosa. CT scan suggests saccular dilation of left lower bronchi. Assessment: post-pneumatic bronchiectasis, left lower lobe, excessive airway secretions and sputum production causing coarse crackles and sputum expectoration. Acute bronchial infection and hemoptysis causing yellow and blood-streaked sputum. Moderate hypoxemia causing low SpO2. Plan implemented were oxygen protocol, 2 liters nasal cannula prescribed, aerosol medication therapy protocol, albuterol Q4 given via MDI, bronchopulmonary hygiene protocol, autogenic breathing with high-frequency chest percussion via pneumovest. The discharge plan: the physician prescribed antibiotics and administered a pneumococcal vaccine. The patient was discharged from the hospital after 5 days with considerable improvement. However, she was still producing small amount of thin, clear sputum. She was instructed to seek prompt medical attention for all future pulmonary infections. Family members were instructed in manual chest percussion and postural drainage techniques. The patient was given QVAR to be taken twice per day. Readmission: 2 months later, the patient arrived at the emergency department complaining of a productive cough. Pain on the left side chest made worse by deep breathing, shaking, chills, fever for the past 3 days, and a noticeable swelling of both ankles. Since previous check, patient admits only doing her manual CPT and postural drainage only once to twice per week. She also mentioned to forget taking inhaler medication from time to time. Her sputum was foul-smelling, thick, yellow, and green. Cough was strong. Auscultation of breath sounds were coarse crackles over the bases. There was mild clubbing of the fingers and toes. Physical examination revealed patient to be in respiratory distress. Her vital signs showed elevated blood pressure of 160 over 100, elevated heart rate of 110 beats per minute, elevated respiratory rate of 20 breaths per minute, elevated temperature of 101.5 degrees Fahrenheit. Arterial blood gas showed a pH of 7.51, PaCO2 of 28, PO2 45, bicarb 21, showing acute alveolar hyperventilation with moderate hypoxemia.
This now brings us to the discussion section. The most prominent concern for the respiratory therapist providing care for the bronchiectasis patient is effective and efficient elimination of excessive bronchopulmonary secretions. Clinical manifestations presented in the case study were coarse crackles, tachycardia and increased blood pressure, and acute alveolar hyperventilation with moderate hypoxemia. Active implementation of bronchopulmonary hygiene therapy is important to help break down and mobilize secretions as soon as possible to prevent the formation of mucus plugs. Autogenic breathing maneuvers were taught to the patient to help move secretions from the lower to the higher airways and to eventually be expectorated. Suggested use of a chest percussion device was to help break down and remove secretions off the surface of the airways. Some other adjunct therapies would be the use of mucolytics, such as Dornase alpha or acetylcysteine, expectorants, such as guaifenesin, humidified bland aerosol therapy to help moisturize the secretions, intermittent percussive ventilation, such as metaneb. Also, positive expiratory pressure devices or PEP devices and flutter valve devices will help, and mechanical insufflation-exsufflation devices, also known as cough assist, help when the patient doesn't have enough expiratory flow to expectorate their secretions. Just like oxygen therapy greatly improves the quality of life and is beneficial to the COPD patient, the same is true for the bronchiectasis patient. Due to the presence of hypersecretions, the likelihood of mucus plugging increases, which eventually leads to pulmonary shunting, causing the patient to then become hypoxemic. Oxygen also decreases the work of breathing and myocardial work. Aerosolized medications, such as albuterol, allow the bronchiectasis patient to manage their bronchospasm. A couple ways that the hypoxemia clinically manifested were through the presence of digital clubbing and a low PaO2 on the ABG. Other therapies that could have been implemented are lung expansion therapy to reverse and prevent the occurrence of atelectasis and mechanical ventilation therapy, either invasively if the patient's condition continues to deteriorate or non-invasively as a preventative measure to avoid intubation or for chronic management of the bronchiectasis patient. The azithromycin given to our patient upon admission is a wide-spectrum antibiotic that was administered to start combating any number of potential respiratory bacterial infections that could have been present. The prednisone that was given is a steroid to reduce the inflammation that can come from both infection and bronchospasm. Once the sputum culture was resulted, levofloxacin was prescribed to combat the current infection of Pseudomonas aeruginosa. The pneumococcal vaccination that our patient received prior to being discharged was given as a prophylactic measure to prevent the reoccurrence of future respiratory infections, specifically those from Streptococcus pneumonia. Tobramycin would be a good drug to start considering for the infection that the patient was readmitted with. Lastly, during the readmission, patient noncompliance was evident, which further complicated the patient's respiratory disorder. In response to the patient's condition, the whole respiratory care regimen should be upregulated by an increase in frequency of treatments with a strong emphasis on the patient's responsibility for her own care. This patient is a prime candidate for pulmonary rehabilitation to prevent her from further hospitalization by getting consistent patient education, being able to have support from others with similar diseases, and so that she can learn her limits and how to expend energy through the day. This now concludes our bronchiectasis case study presentation. Thank you for taking the time to watch our presentation. If there are any questions, now would be the time to ask.